Welcome to today's video conference. I'm Sandy Close, Director of Ethnic Media Services. Today, our focus is on the science of the pandemic, what we know, what we need to know about the virus, vaccines, and ways to prevent the spread. And now I'm turning the conference over to our moderator, Sunita Sarabji.
Thank you once again for joining us on this call. Today we have three amazing speakers that will tell us what we still need to know, what we've done so far, and what's worked and what hasn't. Without further ado, I would like to present Dr. Nguyen of UCSF.
Thank you so much, Sunita and Sandy and everyone else. In the first 14 weeks of the pandemic, when we thought things were going really badly, there were 2 million infections. In the last 8 weeks, we have 3.3 million infections. California, Florida, and Texas have all passed the 500,000 case threshold. California is almost at 600,000. The only slight bit of optimism is that the trend in the number of new cases have been decreasing in quite a few of the states. However, to balance that optimism, as we would expect, because deaths usually lag behind new cases, the trend line for the last 2 weeks show an 11.6% increase in deaths nationally from COVID. A report from the CDC looked at 79 counties in the United States identified as hotspots for the pandemic in the first 2 weeks of June. The first thing about that report that was shocking is there were actually 205 counties that were hotspots in 33 states, covering 93 million Americans. However, only 79 counties, or 39% of them, had adequate race data. In other words, they couldn't analyze the other ones for racial and ethnic disparities. I think that's an indictment of our government, our public health, and our healthcare system, that we can't even collect data on our people. 76 of the 79 counties that actually had adequate race data, 76 of those counties had racial ethnic disparities. 59 of them reporting disparities for Latinx, 22 for Black Americans, 19 for Pacific Islanders, 4 for Asian Americans, and 3 for Indigenous people. So the disparities issues that we've seen early on in the pandemic has persisted. No matter which state, it moves from, New York, California, now it's in Mississippi, Alabama, it still persists throughout whichever states we're talking about. Again, I'm giving you numbers, and there are a lot of numbers, but they're just shocking numbers. During June, 40% of the 5,000 or so respondents in the survey reported mental health issues, including 11% who had considered suicide in the last 30 days. 11%, 1 out of 10 people. For comparison purposes, the usual rate of having suicidal thoughts in the United States in the last year, 12 months, is about 4%. Young adults in particular had much higher rates than older adults. 75% of those aged 18 to 24 reported some kind of mental health issues. And a staggering 25%, 1 out of 4, report having thoughts about suicide in the preceding 30 days. And no surprise to us, Black and Latinx reported higher rates of mental distress compared to whites, with twice as many Black and Latinx people reporting suicidal thoughts compared to whites. Other things from that survey that I thought was incredibly important to share with you: almost 1 out of 3 Americans who had a less than high school education reported suicidal thoughts. And 22% of essential workers did too. Although when they did a multivariate analysis, mental health distress was not significantly worse among them compared to other workers. A major new finding that I thought from this study was that unpaid caregivers also had a suicidal thought rate of 30%. And they were 3 times more likely to have suicidal thoughts or start using substances to cope compared to those who are not unpaid caregivers. So from a disparities perspective, what this says to me is that not only are racial and ethnic minority people dying more from COVID, getting more COVID, dying more from COVID, their family caregivers are actually suffering more as well. And as distressing as this study on mental distress is, I think it's going to get worse. There are reports that up to 30 million more Americans will become housing insecure due to the economic impact. And I'm now viewing the COVID-19 pandemic as being more than about a single disease caused by a single virus. We are witnessing the beginning of an associated epidemics of mental illness, bad outcomes in many other diseases, and a terrible, terrible change in the social determinants of health, such as income, employment, and housing. The metaphor that I'm using is that the pandemic is a meteor drop on the earth, and in addition to the direct destruction underneath it, we are also seeing the ripples of shock waves in all healthcare system and just generally society. I'll finish with a little bit about children. There's been some back and forth about children and COVID, an important topic as we consider what to do with schools. The number of infections among children have been rising. So as of July 30th, there were nearly 340,000 children who had COVID, with an infection rate of about 447 per 100,000. A third of those cases were reported just in the last 2 weeks of July. The states with the worst infection rate among children were Arizona, with almost 1,100 cases per 100,000. South Carolina had 959. Louisiana had 859. Mississippi with almost 800, and Florida with 711. Just FYI, the American Academy of Pediatrics had issued recommendation that children age 2 and older should wear face covering when they cannot socially distance. There's been some debate about whether or not a 3-year-old can actually put a mask on and not put a mask on and keep it on. There's been some sort of anecdotal evidence that they can. But the American Academy of Pediatrics says that if you're going to put kids back in school, they have to wear a mask. Children who get COVID do not get sick as adults, but they do get hospitalized at a rate of about 8 out of 100,000. And when they do, a third of them end up in the intensive care unit, just like adults. And again, the same story with disparities. Racial ethnic disparities for adults have been shown for kids as well. Compared to white infected children, the rate of hospitalization for Black infected children was 5 times higher, and for Latinx children was 8 times higher. I'm going to finish with this one last statement, which is that I think the function of science, which is what I'm here to tell you about, is to guide policy decisions. And it wouldn't do for me to ignore policy decisions that are contrary to science. So here's my update on our leadership's policies through the lens of science. The children data directly contradicts President Trump's statement that kids are virtually immune to COVID. And if you have attended the prior briefings, I have said over and over again that his statement about the efficacy of hydroxychloroquine is not only contrary to the scientific findings, as a clinician, I think it is malpractice. And then his statements about masks not being helpful in preventing COVID-19 infection is wrong based on scientific findings. Thank you.
Thank you, Dr. Nguyen. I'd like to next bring on Dr. Nirav Shah of Stanford. Dr. Shah, when I heard you at a previous briefing in May, you said that the US and the world at large was being very optimistic about having a vaccine and drug therapy by the end of this year. And I wonder if anything has changed in the few months since I last heard you speak.
Well, I'm not going to be getting on a flight to Russia and rolling up my sleeve for their vaccine. So perhaps technically I'm wrong. There is an approved vaccine. The reality is that any vaccine that's been actually tested using normal standards is going to have side effects, is going to be hard to take, and the efficacy is not going to be what we ultimately will have for efficacy 6 months, 9 months down the line. When you first release a vaccine, the vaccines are full of side effects. You can see in the small studies of a few dozen patients that have been done, they've all been done in healthy young volunteers. Healthy young volunteers require 2 doses of the Moderna vaccine and have a lot of side effects. Now, when they tested among 30,000 people, I imagine there will be many more side effects in people who are not young and healthy. And those are the people we want to protect first. So as much as if it's a perfect world and everything happens right and we have a vaccine released that we actually trust and believe in the Western world or in the Eastern world, in China, by January, it won't be ready for prime time. We won't have enough doses until at least 6 months later at any scenario. And if you ask people that question, will it be ready? Will it lead to herd immunity and all of the things that we really need from a vaccine? I think they will agree. When you ask the question, will we have a vaccine? People will say yes.
Please continue with your presentation, Dr. Shah.
You know, we have been talking about how do we control this virus, and there are differences of opinion. Do we go on one end with total containment and eventual elimination, like New Zealand, like Taiwan, and like some other countries? Or do we go toward herd immunity, like Sweden and Brazil? So the opportunities between one end of the spectrum, which is letting the virus run rampant and trying to get everyone to herd immunity, has serious consequences. We've seen how many people die. The rates of the virus in the community reflect how many people die in nursing homes, how many of our vulnerable don't make it. On the other hand, we've seen very successful control. And so we've seen very successful strategies, including opening and keeping schools open in Asian countries who've tried successfully with containment. And so right now there's a false choice between lives and livelihoods. Do we save lives or do we keep people working? It's a false choice. You can have both. And we know what that answer is. And it isn't herd immunity, which is a nice clean term for saying we're not going to try to fix anything. We're going to just let everything go on as normal and ignore the science. So what do we need to actually reopen safely? This is not rocket science. You could make this slide yourself. We need an early warning system. We need broad and efficient testing. We need effective quarantine, treatment, data, and vaccines. Let's go to the next slide. So what is an early warning system? This is an example of an early warning system. 1.5 million smart thermometers in America that at the first sign of illness, you take your temperature at home, it creates a signal that is captured on the internet and tells you where there's unexpected fever hotspots in the country. This early warning system gives an 18-day early warning, a leading indicator, early warning of where COVID is in the community before you wait for someone to get sick enough, feel bad enough to get tested. Tests, by the way, take 3, 5, 7, 10 days to come back now. Show up at a healthcare system, get admitted to the hospital, and die. Right now, we're relying on lagging indicators. People dying from COVID, people waiting to get hospitalized for COVID, waiting for cases to turn positive, versus a leading indicator that has been validated now across the country in every city that they've looked with 12 to 18 days. This is not rocket science. It's simple. It's a thermometer that connects to the internet with some predictive analytics on whether it's flu or COVID, along with a symptom checker in the app. These are the kinds of things we should deploy across the world, frankly, in my opinion. Efficient testing. This has been one story of a disaster after another. We're actually doing less testing today in America than we were doing just a few weeks ago. The hope is that antigen tests, which are low cost, instead of $50 or $100, they only cost $5 to $15 once they're at scale, at the point of care with a turnaround time, which means from taking the test to getting the answer, 15 minutes perhaps, right? That is what we need. There's going to be a lot of these tests available. There are going to be many stories about how confusing they are. The short version of the story is, if you have an antigen test, if you have a positive test, then you do have COVID. If it's a negative test, you shouldn't necessarily trust it. That's a broad generalization, but there's a lot of information on testing out there now. Please stay tuned for antigen tests and how they will help us across the board. When you have a normal test, a molecular test, something you've heard called PCR for diagnosis, coming back 3, 5, 7, 10 days later, by that time, the virus has already spread. It's less than useless. And our government has created this problem by paying people $100 for this test, as opposed to the $50 it actually costs them, and paying people even if the test results come back 3 or more days later. They should not pay for a test result 3 or more days later with a COVID test. Next slide. And the slide is blank. This is the state of affairs in America. We don't have it. We know what we need to do. Other countries are giving 2 weeks of free Netflix. So when you're stuck in quarantine, you have something to do. They're giving hotel rooms. They're taking people away from their families because intra-family spread indoors in a tightly packed environment is how a lot of the spread is occurring. And we don't have systematic ways to do effective quarantine or isolation in America as of now. Treatments, a lot of treatments are being made. There is not going to be one treatment that works. 169 treatments in various stages of development right now. And we will find that, for example, steroids, cheap, in use for many years, decreases death by 20 to 50%, depending on the population. That's a big deal. And it's a cheap medicine that's been around a long time. Remdesivir and others all will help add incrementally so that our death rate goes down. And that's the short story on treatments. Vaccines. So the one approved, I'm not going to line up for, I hope you don't either, in Russia. But there are about 39 in phase 1 through phase 4 of study, which is optimistic. There are other studies around repurposing of the BCG vaccine, which I'm not describing here. But this is a story of success where science has moved quickly together to find many different potential ways to create a vaccine. Again, no hope for any time in the near future. I'm personally not optimistic that we'll have widespread availability of vaccines until Q1, at least Q2 of next year. And this goes into some of the details of the most promising 5 vaccine candidates. And I won't go into more details here other than to say that this is going to be hard to prove, right? You need to test a vaccine in a place where there's a lot of COVID going on. So they're rushing to try to recruit people where COVID is going up. Only then will you see, is a vaccine effective relative to not getting a vaccine in preventing spread. And so the numbers are staggering. 30,000 people need to be enrolled for a study. That's very hard to coordinate, very hard to do. And that's why I'm saying, don't hold your breath, be optimistic, but let's wait and see what happens. Be very measured. A lot of metrics and data. We talked about needs for data. This is a group called Resolve to Save Lives. Former CDC head Tom Frieden is one of the leaders of this. These are some of the 15 metrics he talks about that we need to be talking about and reporting publicly daily at the state and local level if we can. We're doing a horrible job of this. Horrible job. As a nation, we do not have a good reporting system. Even as you've heard the stories publicly about the CDC versus HHS reporting data, we really need to start to think about a fundamentally different approach to this that protects privacy and still allows for public health to do its work. This is one of the examples of actionable data at the US level for 3,000 plus counties. And it tries to summarize some of the most important metrics of 5 indicators: the daily new case count, the infection rate, how many people are testing positive, how much room do you have in the hospital, do you even have tracing capacity in a state? And this tries to give decision makers easy ways to understand, are you at risk? Are you actually in an outbreak, or are you doing well? You can see most of America still has an R0 or RT of greater than 1. They're yellow, orange, or red. Only 2 states have an R0 of less than 1. And so that means that we are not anywhere close to doing well. I'll stop there.
Thank you so much for your comments, Dr. Shah. I'd like to next introduce Dr. Ashish Jha of Harvard School of Public Health. Welcome, Dr. Jha.
Thank you so much. So I'm going to speak briefly to talk about what has the experience been in other countries and what the US can learn from that. And my hope is that we have plenty of time for questions. So I don't have slides, so I'm just going to make 3 or 4 high-level remarks. The first is that America may have the worst response of any country in the world to this pandemic. It's close. You could argue that Brazil, Russia, Turkey, possibly some of the data out of Russia and Turkey are a little less reliable, but certainly Brazil has had a response as bad as ours. But those are the main countries. We're doing much, much worse in most ways compared to Western European countries, compared to Southeast Asian countries. And, but when you look at the US response, there are actually 2 responses in one. Parts of the United States have actually done quite well. They look a lot like Western Europe, being hit hard early, locking down aggressively, keeping case numbers reasonably low. About 1/3 of the US right now is in reasonably good shape, whereas another 1/3 is in very bad shape, and in 1/3, the middle third could kind of go in either direction. So a lot of variation in the United States. Second big point is that it's very tempting when you look across the globe to look for explanations for why other countries are doing better. And I've now done enough of these panels and conversations that I've heard completely opposite theories. One is, for instance, that authoritarian countries do better. Except I started off saying countries that are doing poorly include Brazil and Russia, so that's not really consistent. There are some people who say, well, it's actually cultural and East Asian countries do better. Well, a lot of East Asian countries have done very well, but so have certain European countries. So I don't believe that there is something kind of inherently cultural about certain countries' responses or their people that makes it easier. So seriously, the virus has been taken. We have had an incredible amount of misinformation spread often through social media outlets like Facebook. We've had a political and leadership, both at the federal level and at many state levels, that have largely adhered to that misinformation and promoted that misinformation and have failed to take science as the primary guiding principle. Look, it's a pandemic with a virus. And so this is almost all about biology and math. And if you decide you're going to ignore both the biology and the math of this virus, it is unlikely that you'll end up doing very well. And that's what we have seen pretty consistently. Third big picture point is that you don't have to be a wealthy country to do well. And if we had been doing this session a few weeks ago, I could have made the case, and I'll still make the case, but 3 or 4 weeks ago, I would have said Vietnam, one of the kind of absolute standouts, has not had a single death. Well, in the last couple of weeks, they've had a couple of large outbreaks, and now they have had a few deaths. But it's still trivial compared to what has happened in the US and in many other places. So does Vietnam have access to some therapies that America does not? Nope. They don't have any new special diagnostics. They certainly don't have a vaccine. So what is different about Vietnam, what is different about Taiwan, and let's talk about Vietnam because it's not as wealthy as Taiwan, is that fundamentally they have taken a very aggressive approach to this virus. They shut down their travel early with China. They've screened people coming in. They've had a very aggressive contact tracing regime. So there's a lot that Vietnam has done well to keep the virus under reasonable control. What's important is that the Vietnam approach is actually pretty different than the South Korea approach, which has really relied heavily on testing, which is pretty different than the New Zealand approach, which has relied largely on lockdowns, which is pretty different from the German approach, which has been this blend of many things, which is also different from the Japanese approach, where they haven't done a ton of testing, but they've had universal masking. So what's my point? My point is there is no one way to deal with this virus. There are 4 or 5 major tools we have. You have to deploy at least one of them really, really effectively, and the others become a supplement. You can almost pick which one you want to deploy. In the US, we've done a half-hearted approach to a whole bunch of different things, politicize things that clearly have no basis being political, such as whether people should wear masks or not, and have had a whole lot of misguided, non-science-based policy implementation that has landed us where we are. So let me just finish off by saying, as I look to the future, the weeks and months ahead, the fall, the winter, into the spring of 2021, and I agree with Dr. Shah, by the way, that we will not have a vaccine that's safe, effective, and widely available in 2020. I think that is highly, highly unlikely. But in 2021, we might. I mean, we will in 2021. I'm pretty confident, and we will. My hope is in the first half of 2021, but not necessarily much before that. Okay, so as we look out, let me make one last point, which is to think and realize that America is a very heterogeneous country, and I expect that different parts of America will do very, very differently. And there will be parts of America that we can point to that will look every bit as good as Europe. There will be parts of America that we will point to that will look every bit as bad as Brazil. And fundamentally, what we're looking at is 50 different pandemic responses in the middle of a global outbreak. This is no way to run a pandemic, but that's where we are as a nation. And I think America is going to continue to muddle through it with enormous amounts of suffering and death until we get to a point where we do have a vaccine. The vaccine won't shut everything off. It's not going to be 98% effective, but it has real potential for substantially slowing the spread of the disease and bringing the pandemic under much better control. So that's the future ahead of us. Obviously, things can change if policymakers decide to get serious. There are plenty of lessons to learn from abroad, not one, but the single biggest lesson is to take the virus seriously and let biology and math drive the decision making. Let me stop there.
Dr. Jha, I would like to ask you about what's going on in India. India has a population that's about 4 times the size of the US. It's got 1.5 million in infections and I think about 30,000 deaths. What's going on there, and why has India been able to more effectively control the virus?
Yeah, so India is very interesting. India is very interesting because it was one of the few countries to do a very aggressive lockdown very early. We can talk about the lockdown and the way it was implemented, and there were real problems with migrant workers and a whole set of complex issues, which I'm happy to get into. But the big picture point is, if what I'm arguing, which is that the single biggest differentiator between successful countries and unsuccessful countries is taking the virus seriously, India took the virus seriously. And the lockdowns were clearly effective at maintaining a relatively low level of community spread. That's the good news. The bad news, of course, lockdowns are incredibly expensive, especially for a country like India with large numbers of poor people, a lot of migrant workers, a lot of day laborers. You can't stay locked down. It has pushed millions of people into poverty. And so they needed to open up. But when they did, it became very clear that they had not planned for a long-term pandemic. There really was this magical thinking that somehow the pandemic was just going to be over in a couple of months. Second, they had not built up the testing infrastructure that was necessary, and they had not communicated effectively to the Indian people what a long road ahead there was. And so now the government has really been scrambling, and I would say India is in bad shape, getting worse. So it's true that compared to the United States, India is looking pretty good right now, but it is generating more cases per day now than the US is. And it's still very much in kind of exponential growth. And I expect the number of new cases per day and deaths per day to continue increasing for some time. Last point is that whereas the initial outbreaks were in Chennai and Mumbai and Delhi and parts of Gujarat, the wealthiest, most cosmopolitan, most global cities of India, the largest increases now are happening in Bihar and Uttar Pradesh, which have very, very weak health systems, very little testing capacity, but very large populations. And so I am deeply worried about India, where it is today, and more importantly, where it will be in the weeks and months ahead.
Thank you to our speakers for joining us. Sandy, I'll let you close.
We're really grateful. Thank you.